Hi all, I'm Gabriela Houston. Welcome to my show where we talk about storytelling in all its forms. On the show, I talk to artists, journalists, researchers, other writers, of course, and more about how they use storytelling in their jobs and life. This week's guest is Dr. Rhoda Akilapa, a consultant in clinical genetics. She's the winner of the UK Clinical Genetics Group UK Poster Prize and a member of a variety of medical organizations such as Skeletal Dysplasia Group, Clinical Genetics Society, British Society of Genetic Medicine, and General Medicinal Council. Rhoda, thank you so much for coming. So before we start, could you explain very briefly what your work entails and the
Yep,
kind
of
of
course.
conditions you deal with?
Of course. Thanks very much for having me, Gabriella. So yes, as you said, I'm a clinical geneticist. Here in the UK, that means that I'm a medically trained doctor, and most clinical geneticists have our training in either adult medicine or pediatric medicine, and then go on to do higher specialist training in clinical genetics. And so we specialize in seeing children and adults with rare genetic conditions. And of course, genetic conditions affect people throughout their lives. So we see patients from tiny babies all the way through to the elderly, and we even see couples who are planning to start a family, so thinking about genetic risks in the antenatal period. And we also even sometimes get referred families after somebody has passed away and on post-mortem has been found to possibly have a genetic condition. So it's really kind of a cradle to the grave specialty.
And pre-cradle as well.
Pre-cradle, yes, exactly. So in terms of the kind of patients that I see, because I did my core training in pediatrics, I do see a lot of children, but also adults as well, as I've said. And my specialist interest is more in rare genetic disorders that affect the bones. So that's the skeletal dysplasia side, but also rare genetic conditions that affect the connective tissues as well. So an example of that might be a condition like Marfan syndrome, one of the more common types of connective tissue disorders, disorders that cause sort of hypermobility and can affect the blood vessels as well.
I see. Wow, that is very impressive. um, I mean, so when we were talking earlier about the kind of patients you see, you work closely with families that are facing some of the hardest trials of their lives. So how do you approach explaining to people what's happening? And some of them have very little, might have very little education, they might have very little awareness of the conditions you're describing.
Yeah, that's a good question. I think for a lot of these families, often if it's a child that's got a genetic condition that we don't have the answer to, they've already been on a kind of diagnostic odyssey. So they've been through, probably primary care, secondary care, probably been referred and had lots of investigations, and there's no diagnosis as yet. So by the time they come to clinical genetics, often there's quite a lot of frustration. And so I think talking about the genetic conditions, I think for a lot of the family, if we are able to find a diagnosis, it brings them a degree of relief. And I think also when I'm thinking about approaching giving the diagnosis, I have to kind of explore what that family's sort of current ideas are, because I think
Mm.
often if you're in a situation where a child has a rare condition, or the individual themselves have a rare condition, approaching a family to kind of talk about the genetic diagnosis, I think I first of all have to get a feel for where that family is at. I think often if you have a child who has an unexplained genetic condition, and there hasn't been an explanation up until now, parents often might in their mind formulate reasons for why this may have happened. And often when you speak to people, you kind of tease out ideas like, maybe because I took this medication in pregnancy, or maybe because I did this or did that. And in some families, it may even be a sort of spiritual idea that they might have as to why this has happened. So having to kind of really go right down to the basic sciences of genetics and explain that, all of us are made up of these millions and millions of cells, and the instructions to how we grow and develop within our genes, within our
Mm,
DNA, and just explaining the fact that all of us have this genome with these sort of 20,000 or so genes, and everybody has on average about 100 to 200 spelling mistakes across our genes. So nobody is perfect, but within this set of 20,000 genes, the instructions of how our bodies are sort of built,
mm,
we have two sets because we have one set from mum and one set from dad. So even though we all have this sort of 100 to 200 spelling mistakes, most of the time it doesn't cause any condition, because if one gene's not working, well, we've got the other one that acts as a backup. So it's really by chance you might be in a situation where a child might inherit a gene that's not working, so a faulty gene, for instance, from mum, but then also happens to inherit a faulty gene on that same gene from dad, and parents just happen to both be carriers of a condition without knowing, and that's how a genetic condition may have arisen.
mm,
But also equally, it can be that it's a specific type of spelling mistake on a gene where you do need both copies to be working. We call those dominant gene change. So you have one gene that's working perfectly fine, but one that has a spelling mistake that actually dominates over that normal copy.
mm,
And that's something that can happen just at the point of conception, where the sperm meets the egg, and it just
yeah.
happens out of the blue. So again, just explaining the story of how these genetic mechanisms can cause these conditions. And as I say, for the most part, this is something that's just completely spontaneous, out of the blue, not anything that's been caused by anybody's action, but just something that we don't have control
Mm.
over.
I
Yeah.
mean, I love how you jumped right into the storytelling element of it, which is, of course, what the show's about. And, when you sort of compare those sort of, issues with the genes as sort of spelling mistakes, that really kind of takes the sort of the stigma out of it in a way, like just the language you use. And I think that is just so crucial, because like what you're describing is we're already dealing with something incredibly personal, and when described in the wrong way, people could really feel like I am faulty, like not
Mm,
just this faulty gene, like this is my
mm,
fault because I carried this thing that's hurting my child. And that is just not a productive or helpful way to look at it. But that is, when people are looking for like the thing that is at fault, they very
absolutely.
say,
Absolutely, yeah. And I think that the language that we use over time has changed and evolved. So certainly in the medical side, when professionals are sort of talking to each other, clinical scientists are talking to each other, we did often use the word mutation, meaning the
mm,
change in the gene that stops the gene from working. But I think often when you're talking to families, using that word mutation can conjure up all sorts of imagery in the mind. And
absolutely,
so
yeah.
I think often when we're talking to patients or families, we might use the word a spelling mistake, or say faulty gene. But even that, sometimes people can think, oh, so
Faulty,
as you said, I'm
my fault,
faulty, it's my
yeah.
fault. So
uh,
even that sometimes can
mm,
be misconstrued, or taken in a way that's negative, that we're not wanting. And now, sort of the scientific term we would use is a variant. So we would say if it's a variant of that gene, so the sequencing is
mm,
different to how it is in most people, it's a
yeah,
variant. But the thing is, we have to differentiate the variants that are damaging from the variants that are just
yes.
benign. And so now we would say pathogenic variant rather than mutation.
But when you start going into that, you sort of that is going into like quite medicalized language,
It
but
is
because that
medication.
it really affects accessibility. So that's why I thought
Absolutely,
that the
yeah.
spelling mistake in
Yes,
genome
yes,
is just such a
absolutely, yeah.
beautifully clear and easy to understand way to describe it.
Absolutely, yes. And I agree. I think the term spelling mistake, it does give a clear sort of idea of what we're talking about, because the gene is a sequence, and often what happens is that sequence has been sort of swapped around, or one of the letters has been switched from another letter. So I think spelling mistake is a really good way of conveying what's
Very
happening
good analogy,
in
yeah.
a way. Yeah, absolutely, yeah.
And some of the your job as a researcher is to take those incredibly personal stories of your patients and then extract data from them. And then what you have to do is to curate both the data and the stories to pass them on forward, to be able to access funding, to access institutional support. How do you balance out the sort of the cold clinical approach and the human element that, actually helps you get support?
Yeah. I mean, that's an interesting question. And I think from my, you sort of use the word cold clinical. And, when I think of the word clinical, to me, the clinical side is the human side. So I think as a clinical geneticist, that word clinical to me more means caring for that patient, caring for that,
Mm,
whereas the research side is that collecting the data and the information to understand more of the condition. I think people who have rare diseases are a real important group of people, because individually those diseases can be so extremely rare. There may be very, very few people in the country who have that condition, but collectively, if you collect all the rare diseases together, they're actually not that uncommon at all collectively. And so the need for research for those families is so significant, because often when you make a diagnosis of a very rare disease, it's not a case of, oh, you've got this, these are the treatment options available, and it's often, you've got this very rare condition, we don't know very much about it, it's genetic, there's nothing we can do, and it's just a way of you have to kind of then try and optimize quality of life. I
mm,
think things are changing now. Things are definitely changing now, and there's been lots and lots of research. A lot of the research historically was understanding that condition. And so when we're seeing families doing the investigations, making that diagnosis, I think the research aspect is trying to understand as much as we can about the condition itself. And in order to do that, we have to collect all of the information of what's happening to that
mm,
person, and then publish that and collaborate with other specialists around the world who are dealing with people with rare diseases to just try and get as much information together as possible. So even though there may not necessarily be a treatment available, if we understand more about how does this condition affect people, you might be seeing children who are babies to sort of 1, 2, 3 years old who are being diagnosed with this fairly newly
mm,
recognized condition. But if we get more information, we can sort of say, well, actually, we know that there's 300 other people in the world that have this, and the older people have experienced this, so we can give a bit more information to parents and say, well, actually, we know from this data that this might happen in the future. These are the things we need to look out for. So I think that's one aspect of the research, is that observational, collecting the data of other people who have this rare condition
and
from around the world.
collaboration, from what you said, is
Absolutely, yes, and
crucial. Yeah.
collaboration. So it's certainly a specialty where there's a huge amount of collaboration, because one geneticist might have only seen, a very small handful of these patients or this particular condition. But I think the other side of the research aspect is the development of the new treatments. And as I said, historically, it was often, this is a condition, it's very rare, there's no treatment, it's genetic. Whereas now, technology has moved so quickly. We're in a situation now where pharmaceutical industries are definitely taking more of an interest in developing treatments for rare diseases. There are now gene-targeted therapies for specific
Yes.
conditions. And
Gene
so
editing, isn't
gene
it? It's
editing
called.
is one,
Yes.
so the CRISPR-Cas9, and this is something that is really sort of making waves in the scientific community, but also gene targeted, in not necessarily editing the gene, but looking at the way the gene impacts the cell. And so the gene that makes this protein, if the gene's not working properly, what happens to that protein? And if that protein's not there, or if it's faulty, what happens? What's that protein's job? Is there another protein
Hmm.
that can come in and do the job instead? That kind of thing. And so looking at the actual cellular pathway all the way down, and seeing if you can intervene with a specific type of therapy. And so because we have that now, we're always looking at clinical trials, the opportunity for
Hmm.
recruiting patients to clinical trials and
Of
giving that
course.
information to families and being more involved in those things as well. So
I mean,
it is,
that requires a huge amount of money as well. And I
of course,
was
yeah.
interviewing an Amnesty International sort of fundraiser recently, who's basic, and we were talking about the importance of stories in raising funds and how you
Mm,
can connect, because we've seen when it comes to what becomes available in terms of like, public spending on particular treatments, on particular diagnostics, we've seen in the recent years how powerful an individual's story could be. There was that was a few years ago, but there was this lady who was a sort of dental nurse, but she gained popularity as a Big Brother participant, and her name was Jade, I believe. I don't remember her surname, but she very sadly was late diagnosed with cervical cancer. But before she died, she did sort of, try to raise awareness of the fact that this is a highly treatable condition if diagnosed early, and that she really did not need to die. And the public pressure grew to the point where women started getting offered smear tests, every 2 years instead of, what was it before, something ridiculous like every 5 years or something. And suddenly, we are getting this preventative sort of diagnostic, and that was this one story that sparked public support. And there was a similar story, sad story about meningitis B. And now it's this vaccine is being offered to children. So how do you, as a researcher, because you're dealing with diseases that don't affect that many people, and so that makes accessing funding much more difficult in general, because people are weighing up in quite cold terms whether or not that investment makes sense for pharmaceutical companies or things. So how do you use those stories in order to be able to create those clinical trials in the first place?
I think there's kind of two dimensions of what you're talking about there. So I think one aspect of what you're talking about, I remember very clearly that I think it was Jade Gooding, as you said, it was on Big Brother, that sort of wave of awareness of cervical cancer and the need for sort of smear testing. And now, of course, now we have the vaccine for the HPV virus, and that's really sort of made things much better in terms of preventing cases of cervical cancer. And similarly, other key personal stories that get into the mainstream media kind of really ways of awareness. So I think one example I can think of from the genetic side is when Angelina Jolie discovered that she had a BRCA mutation. This is the BRCA gene variant that can cause that significantly increases the risk of developing breast cancer. And when that story went public and Angelina Jolie spoke publicly about her being found to have that running in her family and being found to have that gene change, she then went on to have a double mastectomy to reduce the risk of breast cancer in herself. And we are the referrals to the clinical genetics service for possible family history of breast cancer skyrocketed because that raised that awareness. So I think when a person who has a rare genetic disorder does tell their story, it does raise awareness. And I think specifically for rare conditions, this is something that people might be living with and not know. They may have been to lots of doctors and not had a diagnosis. And I think sometimes we do get lots of referrals sometimes of people who have seen a program on television talking about a rare disease, of personal story, and thinking, gosh, that looks very similar to my child who has similar symptoms. And then they go to the GP and said, what if it's this? We don't know what the diagnosis is. So I think those sort of key stories raise awareness on a wide scale, and it does bring those referrals in, and people sort of realize that, it could be something genetic, and then they might get sort of signposted to the right place. And then the other arm, thinking about funding for research, I think is much more driven by the research into how the genetic condition sort of comes about. So for instance, in order for sort of treatment to be developed, we need to understand the condition more. So I think part of it is can be sometimes driven by, you know, do we have enough people who have this condition? How much do we understand about the condition? And then are pharmaceutical companies going to be interested in obviously developing a gene targeting treatment costs millions and millions of pounds. And so the companies are going to want to know that they can, you know, get their returns from that. And for every treatment that's approved, failed, and then they'd had to start again. And so there's a proportion of, there's an element of that that's sometimes a little bit out of our control. But I think as clinical geneticists, you're kind of having one foot in the clinical side and one foot in the research side. You're almost the kind of bridge. So you're having to communicate with people who are the more research side and pharmaceutical companies and the, you know, more in the academic side, and get those personal stories that you're being faced with day to day from the patient themselves, from their families, and translate that information to the more sort of scientific side to say, look, this is what people are dealing with. These are the conditions that are really important for you to sort of look into. This is what we understand from these conditions. This is the data that we have. And it's really kind of that working together from the clinical and the research side that I think makes progress for these families.
That is a very sort of difficult topic, isn't it? Like, because people don't like thinking about the way that decisions are made, whether or not treatments are going to be developed, you know, to help their loved ones, and just how much that is driven by sort of profit return sort of argument, isn't it?
So I think certainly, I mean, I think often from the genetics side, our main focus is how can we need to understand how this condition comes about to know how to treat it, how to combat it. So how can we make something that is specific to this condition that makes a difference? So the mainstay of treatment is of management is always treating the symptoms, but with a genetic condition, if we're thinking of gene targeted therapy, we're not wanting to just treat the symptoms, we're wanting to change the course of the condition altogether. And before even funding comes into it, is it possible? You know, we're talking about changing your DNA or changing the effect of what the DNA is doing to the cells. So I think often, you know, the first step is, and I think
can it be done?
Yeah,
Is it
exactly.
is it even possible?
Exactly.
I mean, when it comes to you know, dealing with genetic diseases, you obviously also deal with kind of a probability of it occurring. And as a result, you have to deal with very sensitive topics like we were discussing earlier, like a large difference in age between partners, or even more sensitively, the sort of consanguinity issues. Sort of, can you tell us a little bit about that work?
Yeah, no, absolutely. So, I mean, consanguinity meaning that a couple are related by blood. And, you know, I think we talked about it in the past as well, that, you know, consanguinity, a couple who potentially may come together who are second cousins or close or more closely related, for instance, first cousins. That is a practice that has been quite widespread across various parts of the world for millennia, pretty much. And so, you know, here within the UK, we know that Charles Darwin himself was married to his first cousin. There's been lots of, you know, interrelated marriages within the royal family in the past. It was almost kind of romanticized. But then, of course, in the 20th century, in the Western world, there was quite a rapid decline in consanguineous unions. However, in other parts of the world, this is still fairly commonplace. And so there are definitely communities in the UK where that consanguineous union is fairly common still. And of course, I've talked a little bit about the fact that, you know, if you have two spelling mistakes in both copies of the same gene, that can cause what we call a recessive condition. And that can lead to a genetic condition in a child if the baby inherits both sort of
Both
fault.
spelling mistakes in the
Both
same
spelling
gene, yeah.
mistakes, exactly, that are the same. Now, of course, if mum and dad are blood related, so for instance, if they're first cousins, they share 12.5% of their DNA. And so the chances of them having a spelling mistake that just happens to be on the same gene and the same spelling mistake is a little bit higher. But then if you put it into context and say, well, actually, the chance of a couple who are not related having a child who's born with, say, congenital anomalies is about 1 to 2% of any sort of genetic condition happening to that child. 1 to 2%. If they're cousins, if they're related, that risk doubles to about 2 to 4%. So it's a doubling in risk, but the risk is still overall small. We're talking, of course, about a couple who are well, fit and well, with no known family history of any problem. I think if you're coming from a family where there's a known genetic condition, that's different. You need to ask to be referred and see if there is carrier testing that's available that's based on your family
I think
history.
the issue is that, when the risk doubles, and then you think
Mm.
about the parents of the couple who might have been married to their first cousins as well. So that
Mm.
percentage of genes shared
Mm.
increases. So I think especially when we talk about like the traditional sort of marriage between cousins, that
Mm.
won't just be one generation, will it?
Yeah, so certainly there are communities, particularly if you're a community that's migrated to the UK many sort of generations ago, then that sort of first cousin genetic relationship is often intensified if parents are also first cousins. And so it does increase the risk even slightly more than doubling. In some sort of small communities that can be a little bit more isolated, it might even go as high as tripling. But again, I think taking it into context, you touched on difference in age of the parents as well. And so as being in a cousin marriage can double the risk of a child being born with congenital anomalies, having a child over the age of 34 can also double the chance of having a child with congenital anomalies. So it's like a risk factor that increases a certain type of genetic condition. We know that more interrelatedness increases the chance of those what we call recessive conditions inheriting two spelling mistakes that are the same. Advanced maternal age increases the risk of having more structural genetic conditions. So, for instance, one of the most common genetic conditions, Down syndrome, where you have a whole extra chromosome 21 as the woman is advances in maternal age and is over the sort of age of 34, so 35 onwards, the chance of those things happening, so Down syndrome, Edwards-Patau's, also significantly increases as well. And so I think the
And
awareness.
with paternal age as well, you were mentioning
I
with
mean,
anything as
yeah,
well. So it goes both ways. I
it
do
does.
like to note that goes both
Yeah,
ways.
absolutely. It does go both ways. It's slightly different with the paternal age and the type of genetic conditions again. So we talked about the recessive conditions with more interrelatedness. We've talked about the increase of what we call the structural sort of aneuploidy. So that's Down syndrome, etc. With advancing paternal age, not so much as young as 35, but older still, there is an increased chance of what we call dominant spelling mistakes. So I talked about those dominant spelling mistakes where not necessarily you're a carrier, but it just happens out of the blue and it dominates over that normal copy. There's an increased risk of that if there's advanced paternal age as well. So there are all sorts of situations where you can get this increased risk of a certain type of genetic mechanism that can cause a problem with the child. And I think it's the awareness of that matters.
Yeah, I mean, going a little bit back to what you said about how marriage between cousins was norm across the globe, pretty much. And in Europe, like the most famous example of that was the royal family of Habsburg line, right? Who basically intermarried for many, many generations. But people very conveniently sort of forget that in the West now. And that was such a recent thing that it was so recent that marriage between cousins was completely normal. And suddenly it's treated in this sort of deeply stigmatizing way. And I'm, the way you sort of talk about it, as in like comparative risk, I think that's quite helpful
Mm,
for people because it's there's a huge taboo about it in the West now, even
mm,
though once again it was considered perfectly normal,
mm,
very sort of recently, and but the stigmatizing is really unhelpful when discussing it with
mm.
um with the communities, isn't it? Like how do you sort of treat that as a clinician, like because you will come across people being very outspoken about their views on consanguinity.
Yeah, no, you're absolutely right. And I think from my personal view and opinion has always been, I guess, observing that community, observing what their sort of cultural practices are, and it's not something. In order to kind of understand the reasons why people do things, you really need to kind of talk to people, delve into the history. And as you said, this is something that was very recent in the UK as well. And so I think, to me, these cultural practices are what they are. There are various reasons why people might go into a consanguineous union. Certainly, lots of research and publications has been done of people from outside the communities trying to understand why people within the
Mm,
communities do choose to marry a first cousin or second cousin, and various sort of reasons have been suggested, such as keeping wealth within the family, greater protections, particularly for the bride,
mm,
have sort of strengthening that cultural and family bonds between both sides of the family. And to me, all of those things are fascinating, and I think that that is that community's practice. Similarly,
thank
like
you.
in the West, our evolving practice seems to be people waiting later to have families as well. So I think each cultural sort of group looks at another group and sort of doesn't understand necessarily why we do things. But from the clinical point of view, I think that my aim and my goal is to raise awareness. So, for instance, if you are from an ethnic group where there is a higher risk of a specific type of genetic condition, that's something that I will be, then your ethnic group is important. It matters to me. So, for instance, if you are from the Ashkenazi Jewish community, there will be certain conditions that I will be thinking about higher on my list. If you are from a family where there's a lot of first cousin marriage, there are certain conditions or types of conditions that will be higher on my list. Similarly, there is, if mum is an older, more mature mum, there will be certain conditions on my list. And similarly, if you're from, say, for instance, West Africa, so Nigeria, where I'm from, the carrier rate of a common genetic condition like sickle cell is as high as 1 in 3. If you're from, the white European population, the carrier risk of something like cystic fibrosis is 1 in 25. So I think there are so many different aspects that can affect
Mm,
the frequency, the prevalence, the risk of genetic conditions. From my point of view, it's not to sort of look at one group and say, oh, this, and kind of try and unpick that. It's more about recognizing what those risks are across
mm,
the board, and increasing that awareness, because most of the people who discover that they have a genetic condition or get a genetic diagnosis, they find out after the fact. And I think there is power in knowing what that diagnosis is in the family before you're in a situation where you're going to go on and
mm,
start your family. And so if you're empowered to have knowledge of what your risks are even before you enter a long-term relationship, before you start planning your family, then you have more options that are available to you, rather than for the majority of people who, it's when it happens, it's after the fact, the diagnosis is made. Having the diagnosis is helpful, because it does still open up more opportunities and treatments and things. But I think that information is even more helpful to those younger people in the family who have that information before
mm.
they go on to make those huge kind of life, decisions.
Absolutely. But I think that your approach with sort of understanding the reasons behind and just being uh a bit more neutral about how you present facts to people is just it makes it a lot easier for people to take this information on board, because I
Mm,
feel that sometimes the way it's discussed in the sort of Western media, or it's or sort of Western medical organizations, it can feel very stigmatizing. And of course, when you approach such a sensitive, culturally based issue without
mm,
understanding the reasons behind it, people just
mm,
shut down and they close ranks and they will not
mm,
let you in. And
mm,
how do you sort of approach, because there is this understanding gap, I think, between a lot of Western organizations that are trying to address the issue um, of marriage, but between close family members, and what would actually be helpful in approaching mixed communities. So I know that you have done some work trying to sort of maybe educate on the risk factors. Uh,
mm.
so can you tell me about that experience?
Yeah, no, absolutely. So yeah, no, I agree that you know approaching things in the wrong way can be really quite damaging, and will have the opposite effect of what you want. So what we're wanting is the best health outcomes for the community at large, on the whole. So I was involved some years ago now in a project, working with the local community in Luton, which involved a number of different organisations. It was kind of a health awareness day, where I was able to give some talks talking about the issue of consanguinity and just, opening it up to questions, explaining what the actual figures are, and trying to demystify any sort of myths and ideas that people had, and just also signposting people to say, these are the things that we can do. If you are worried, do ask to be referred to clinical genetics to discuss your unique situation. Um, there are lots of, I think as a whole, organizations have made a lot of progress in this area. And I think this is a topic that in the past may have been dealt with insensitively, and there has been backlash from that in the past. And I think as a result, lots of organizations have learned a huge amount. And the organizations that I worked with in Luton were very, very good and very well versed in the topic of consanguinity, very much embedded in the community, and it was really a far cry from what may have gone before. And huge sort of research projects, like there's a project called Born in Bradford, which has been collecting data for many years within the Bradford community, which has a large British Pakistani community who are from a specific part of Pakistan. And so the genetics of that community is quite unique. And that data has been really sort of helpful in terms of furthering our understanding of the different types of genetic conditions within the UK in our non-white population. I think following on from the Born in Bradford study, that sort of takes my mind to the sort of bringing to the forefront the realization that a huge amount of research that's gone into clinical genetics is really focused on European community, and a lot of the tests that we have set up are really focused on the knowledge we have from populations of mainly European, though we do have data from other ethnicities as well, but it's limited. And so, for instance, if you were doing a genetic test for, say, for instance, cystic fibrosis, a large number of the spelling mistakes that are being looked for are much more common in the European
Mm.
population. If you are from an African ancestral background and have a diagnosis of cystic fibrosis, the chances of finding that spelling mistake would be much lower, because they would be testing it against the spelling mistakes that are more common in the European population, and
Mm.
less is known about the genome.
So it can be different spelling mistakes causing the single
The same
condition.
condition, absolutely, yeah. So there are some conditions where the spelling mistake is, there are it's the same spelling mistake over and over again. There's some conditions where there may be 3 or 4 very common spelling mistakes, but rarer ones. And there are many conditions where there are spelling mistakes, specific spelling mistakes that are more common in that ethnicity, but in a different ethnic group, that there might be different spelling mistakes that are more common. And because there's less research in those ethnic groups, we don't know what those spelling mistakes are as much. And so we get lots of what we call variants of uncertain significance, where we see a variation in a gene. We're not quite sure whether this is a spelling mistake that's going to stop the gene from working, or whether this is just a change in sequence that's just unique to that particular person, but benign. And so certainly we know now that if you are somebody of African ancestry living in the UK with a genetic condition and you're having a test, the chances of those variants of uncertain significance coming out in your result will be much higher, because we don't have a really good kind of background of data to test against than if you are from
Yes,
a white
but
Europe.
it's quite a startling discovery to make, isn't it? That if
I mean,
this
I think it's
wealth of
something
research that's been done is actually almost irrelevant to different communities, isn't
yeah. I mean, when you say discovery, I think it's was, it's there,
it?
sort of very sort of blatant. I think over the pandemic period and lockdown, and in the wake of the George Floyd murder, and the Black Lives Matter movement, and the inequity we saw over COVID, and the deaths, and the health inequalities that we saw across different
Mm,
ethnic groups, it did sort of raise awareness of this as being
of
more of an
course.
issue as well. So these are things that I think are on the forefront of clinical genetics at the moment, of really trying to improve the landscape for everybody.
Of course. I think in terms of when I say discovery, it's because the sequencing of the whole human genome is, in historical terms, it's quite a recent discovery in the first place. And when
Absolutely.
you start gathering what you have at hand,
Mm-hmm.
um, and then you realize that actually this is not close to sufficient, and it's like, and little knowledge can be very dangerous, people say. And if you're basing your understanding of genetic conditions on a very small sliver of the population, that can have wider repercussions. I was thinking in terms of back to kind of uh your approach with patients, and like the way you communicate things, because storytelling is also about basically it's about communicating things to each other.
That's right.
And when you're talking about many choices that are situations faced by your patients, are deeply personal, and the way they interpret things, you touched on it a little bit, can be very different. So some people in maybe lack of understanding of the condition will sort of interpret it along more spiritual terms or more kind of cultural terms, and therefore the choices they will make when it comes to handling the information that you give them will be colored by those things. And so sometimes I imagine that the choices they make will go against your professional judgment.
Yeah,
And how do you handle that?
yeah, I think that you're absolutely right in that the background of where that person is coming from will definitely have a huge impact in the way that they interpret that information. And I mean, even something as simple as, is this a completely new condition that nobody in the family has? Or, for the dominant conditions, it may be that the parent themselves has the same condition. One of the features we see of some dominant conditions is that they can be very variable. And so a mum or dad can have the condition and it be very mild, and then the child has the same condition and it's much more severe, for instance. And so a parent might have that same condition and have had their own personal experience, maybe had to have lots of operations and been very ill as a child. And somebody else might have had the exact same condition and had a much milder course, barely noticed any difference, adapted really well, and not really had many problems. And so both completely different people, but with the same condition, same situation, both having a child with the same condition. One person might say, well, I've had this, I've managed it fine, we know early, fantastic, we'll deal with it. whereas the person who's had a terrible experience might think this is absolutely disastrous. I don't want my child to go through this. I would do absolutely everything to prevent passing this on. And so you do see very different sort of reactions, interpretations in the way that people kind of deal with situations based on their own personal experience. And of course, other things like, cultural beliefs can come into that as well. I myself am from a West African Nigerian family by background, although I was born and raised in the UK. And from my own personal experience, I know that my parents, who are Yoruba Nigerian parents, are very, very spiritual, and illness is always has some kind of spiritual context to a degree. And the more serious an illness is, the more likely there is to be some sort of spiritual context. And so I see lots of families who are from backgrounds where there is a very strong spiritual element to their entire lives. And so, particularly if lots of people in the family have a condition, you can very easily see how a spiritual interpretation will come into that. Well, how can this happen to 3 or 4 people in the same family? It must be spiritual. Whereas I'm thinking, well, it's genetic. That's what happens. So,
that's what usually happens with science, isn't it? Because you actually are looking at you're
yeah,
looking at what's causing it, and it's, you still have to communicate to people who might have a very
yeah.
strong belief otherwise.
Otherwise, absolutely. And even with people in my own family, I can be in a situation where I'm explaining something in a scientific way, and they're saying, "Oh, you don't know what you're talking about. This is what I believe, and this is what it is," and you just have to accept that. So certainly with patients who are have maybe from a
Who are
similar
not your mother, yes.
you just, all you can do is sort
You
of
get a little
explain
more
things
respect, maybe.
from the scientific perspective. And whatever sort of spiritual interpretation they have, that's theirs. And all you can do is just do your best to give as much information as you can, to optimize the health of the affected person. And all of the treatments and everything that's available, you may not be able to change anyone's views, and you may, who am I to change somebody's views? But what I do want to do is make sure that there isn't anything harmful there, or any kind of if there's a very strong belief that this is my fault, something that potentially could be quite harmful, this is something that I would try to counteract. But other than that, I think people are just very, very different. And, you often just have to get an idea of where they're coming from and kind of meet them where they're at.
I mean, I think it's just emotionally must be quite difficult because, your job in a way is just to try and get the best possible outcome
Mm,
for your patients. And then, when there's that kind of communication gap, that must be quite sort of heavy to sort of
mhm,
handle. And you are dealing with quite a lot of trauma, and you are then expected in your research capacity to curate those people's trauma for the benefit of science and for their benefit as well,
mm.
but like in long term. Like how do you approach this emotionally?
Yes, it's a good question as well. Yeah. So I think it is a very emotional job. I think across the board of medicine in all specialties, it can be very, very emotional with any condition that you're dealing with. I'm thinking particularly of, oncology and other specialties where you're dealing with sort of quite serious conditions. I think one of the things that's quite unique to genetics is often, because this is something that is in the genes, this is in your DNA, this is something that it's not something that can be changed. And so when you're giving somebody a diagnosis, it's not a case of, oh, you have this infection, here's this antibiotic, it'll take you this long to get better. This is how you were built, how you were designed. This is your diagnosis for the rest of your life, and not that it's there for the rest of your life. This is how you always have been. This is actually information about you. It's just sort of explaining why you are the way that you are, and to try and people do struggle with a genetic diagnosis because it's something that is explaining why something just is in that specific person. And to try and explain that why, particularly if it's something where both parents are carriers, then blame can be attributed and all that kind of thing, and trying to kind of dispel that and say, well, this is just the mechanism, but it could have happened to anybody. And yeah, I think there's a lot of sort of frustration sometimes, a lot of sometimes guilt people feel, and trying to kind of deal with that and help people to sort of overcome that and get in a better place. I think often it takes a lot of people working together. I'm lucky enough to work in a specialist clinic with a multidisciplinary team, and we have a clinical psychologist as part of our team in the skeletal dysplasia clinic who works with children, because it's an ongoing process. Once a person has this diagnosis, it's not just a period of time. This is sort of a lifelong acceptance of that diagnosis, and moving forward into how to best live my life, with this information, and how can I be empowered with this information. And so I think it would be fantastic if every rare disease had its own specialist clinic where families could go and see a whole multidisciplinary team where everyone understood that one condition. But it's not possible for most conditions. But I think this is where we're sort of moving to more and more in clinical genetics in general.
Thank you so much, brother. I think everyone listening to talk about it will come away just a little bit smarter. So thank you so much for coming on
No,
the
thank
show.
you for having me. Thank you for having me. Lovely talking to you, Gabriella.
Thank you for watching the video. Every week there's something different. So click like and subscribe if you would like more. It really helps the channel. Thank you, and see you next week.